Hey there, welcome to Immune Matters, the podcast sponsored by the PIDTC, where we dive into immune deficiency and dysregulation. I'm Dr. Jack McDonnell, a pediatric immunologist at Cleveland Clinic.
And I'm Dr. Elie Haddad. I'm immunologist and bone marrow transplant physician scientist at CHU Saint-Justine in Montreal in the beautiful province of Quebec.
Sounds so nice.
Yeah, it's even more than that.
It's evocative. Yeah.
Yes, and it's just amazing. So you and I both take care about rare immune conditions and people living with them. And the objective of this podcast, we are excited because the objective is to bring you the latest groundbreaking research and insights from the field. So we invite people and we ask them to tell us about them.
And we're always additionally trying to highlight the patient experience. We want this podcast to be accessible to patients and their families who are interested. So we're going to have definitely a focus on that with our episodes, looking at the immune diseases also from the patient perspective. Just a reminder, this podcast is for educational purposes only. It's not medical advice, and the views expressed here don't necessarily reflect those of the PIDTC, the NIH, or our institutions.
Yeah, and we are passionate, so sometimes when we are in the debate, we forget that it's a little bit more for the patient, so we try to go back.
We try to bring it back.
Yeah. And we hope that whether you're a provider, a patient, or just curious, or a big shot in the immune system.
Elie.
No. We're glad you're here, and you're welcome. And that's great to have you here. And now let's get started with this new episode.
All right, and now we're excited to welcome our guest, Dr. Joseph Oved. Joe is a leading expert in bone marrow transplant for a variety of immune conditions and a pioneer in exploring how biologics like Emapalumab that were developed for one indication could be possibly used for other indications. Joe, thank you so much for joining us. Could you just start by telling us a little bit about yourself?
Sure. So I am trained as a pediatric hematologist-oncologist and sort of subspecialized in transplanting curative therapies for non-malignant disease. With a further focus on inborn errors of immunity and hyperinflammatory syndromes. I'm currently at Columbia as an associate professor and leading the efforts in transplant for non-malignant indications, again, immune dysregulation, immune deficiency, and hyperinflammatory syndromes.
Awesome. It's great to have you today. So we really wanted to pick your brain about Emapalumab. I know this is an important medicine that some of our patients will know about because it's used in the world of HLH. One of these things that's hard to say in medicine, so we have to call it by its acronym. Could you just tell us a little bit about this Gamifant business and how it's traditionally used?
Yeah, so Emapalumab or Gamifant is an antibody against interferon-gamma, so one of the immune pathways that can be overactive in HLH and certain other diseases. It is indicated on the label for use in relapse refractory primary HLH. So HLH that is caused for genetic reasons, that has failed standard therapy or has not responded to standard therapy. And it was recently also approved for macrophage activating syndrome, which is similarly on that spectrum of hyperinflammatory syndromes. And what it does is it blocks the interferon-gamma pathway. And so we know in a lot of these syndromes that interferon-gamma is the mediator for a lot of the sequelae of this hyperinflammation. It causes a lot of the hyperinflammation, and it sort of starts this vicious cycle of hyperinflammation that then induces further inflammation, which then causes your capillaries to leak. It causes you to start third spacing, have vital sign changes, things like that. And so the reason that Gamifant is so effective is it really cuts right at the sort of heart of the problem there, right, by blocking that mediator. And so that is the sort of label indications for which it is approved.
So it's funny because when I hear hyperinflammation, from many people think about IL-1, IL-6, and interferon-gamma, sorry for the French accent, but that's the way I say it, makes me more think about T cells. So can you explain a little bit more why it's not IL-6, IL-1, and why it's more interferon-gamma, and what's the link between T cells and inflammation in those situations?
Yeah, so, IL-6, can cause its own hyperinflammatory syndromes. What we're specifically talking about here are the interferon gamma mediated hyperinflammation, as we've sort of coined it. And that is caused by, the interferon gamma produced by T cells that can cause your innate immune cells to then release IL-1, IL-6, all of those mediators that then, instigate the NK cells and APCs to induce further production of the interferon gamma. Um, and the effects of having too much interferon gamma circulating is that it causes a lot of tissue inflammation, where there's, collection of innate immune cells or sort of migration of innate immune cells to there. And with that tissue specific inflammation, you wind up running into problems with, like we mentioned, third spacing of fluid,
Hmm.
liver toxicity, and things like that.
Okay, and what about the specific role of interferon gamma in the period of bone marrow transplantation or even in the rejection, which is something that is very interesting. Many centers, and you were the first to demonstrate that, or to show. Maybe it's not published. You will let us know, but at least the people who work in this field know that when you target interferon gamma, you have less complications, less rejection in those situations where there is hyperinflammation. How does it work in your opinion, specifically during a transplantation?
Yeah, so there's been emerging data that has shown that interferon gamma is toxic for hematopoietic stem cells, and that's particularly true in new or baby hematopoietic stem cells that we put into a patient when we do a transplant. Um, the group in Rome has shown that high levels of interferon gamma measured by CXCL9, which is a biomarker of activated interferon gamma, by day 3 post-transplant is predictive of graft rejection. And so what we think is that, all of this inflammation is both toxic to the stem cells themselves, but also does not create a good milieu in the bone marrow niche for them to sort of home to and really settle down and create progeny like they're supposed to. And so hyperinflammation, high interferon gamma levels in that peri-engraftment period can be very dangerous to the success of the graft.
So
So
we
that
have
Go
Go
ahead,
ahead,
go ahead,
Elie.
Eric.
No, I
No,
was
no,
just going
go.
to say something you were saying made me think about this. So we have blunt tools for transplants and in immune suppression. We have more specific tools, and I know you're kind of a fan, if I'm remembering right, of precision medicine. And so it seems to me that Gamifant or Emapalumab is a very sharp tool. Why is that better than a blunt tool for immune suppression that could also be used? Why is it better for the patient?
Yeah, so some of the blunt tools that you mentioned, like steroids, come with a whole host of issues, including um, susceptibility to infection. Also, they don't interact really well with some of the GVHD prophylaxis that we give, and so can really cause a myriad of problems in the post-transplant period. They also haven't really worked in graft rejection, so that has been sort of the go-to prior, and people have given steroid when they suspect there's an immunologic graft rejection, and most of the time that ends with needing a second transplant. What's nice about emapalumab is that it is a very specific modulator. It's not really changing anything else other than the interferon gamma pathway, right? It has a long half-life, so you give one dose, the half-life of the drug is about 23 days, but it's also inversely proportional to the level of interferon gamma that you have, right? So you'll clear it more quickly if you have a lot of interferon gamma circulating, less quickly if not. And it really, again, gets to the heart of that problem. Interferon gamma has been shown also in the aplastic anemia literature to be directly toxic to stem cells, to survival signals that are needed for stem cell survival, right? And so the ability to block that mediator without causing um, a lot of downstream effects is quite important. Um, the group in Cincinnati, the group in Rome have used it for graft rejection with some variable success. We've used it quite a bit with also some success. And we've also shown, we've identified T cell clones that are interferon gamma secreting T cell clones responsible for graft rejection, and that we're able to sort of neutralize them when we give the imapalumab.
So in the
Some of the
no,
other medications one could think about that are not as specific as emapalumab, but are more specific than steroids or your JAK inhibitors, right, like ruxolitinib. But one of the big problems with them, again, because they're broader than emapalumab, is that one of the side effects is they cause cytopenias. And so if you're trying to get a graft in, right, it's a little bit difficult if this major side effect of your drug is suppressing hematopoiesis.
The more you speak, the more I have questions. I have 3 questions. So I'm going to go one by one, otherwise you're going to hate me. Um, let's go back to the indications in the field of inborn error of immunity, and the particularly the field that we're taking care of, the PIDTC. Which are the good indications of emapalumab? Would you say this type of disease, or just, you know what, test 6CL9, and as long as it's high, just give it? What are your thoughts on that?
I think if we're thinking about this in the context of treating patients not with transplant, I think we need more than just a CXCL9, right? I think we're still understanding what a CXCL9 is. I have patients that have what is likely CAEBV or some form of dysregulated EBV control, with CXCL9s of 30, 40,000, right, that are walking the streets of New York and are totally fine, right? And so I can't justify treating them with emapalumab, um, because clinically they look really well. I think we need to understand a little bit more what the 6CL9 means in different contexts and when it's appropriate to treat and when not.
And in the context of transplantation, do you think that there are specific indications for emapalumab, or you think we should test it in all transplant as long as there is hyperinflammation
You
demonstrated
know,
by HLA
I
or
think
not?
for myeloablative transplants, right, where we are using a myeloablative regimen, busulfan fludarabine with serotherapy, either ATG or Campath, I think that emapalumab for all inborn errors of immunity does make sense to me. As you know, our trial is biomarker guided, but we are exploring starting to add a dose or two in patients, even if their CXCL9 is not high. Again, because we know that that can change very quickly in the post-transplant period. We know that this is protective, not only for graft rejection, but if you look at Sonata Jadel's data, right, interferon-gamma and complement have very close interactions, and are responsible for some of the endothelial damage that evolves into TATMA and things like that. So, I think blocking a little bit of interferon is probably a good thing in the myeloablative setting. I'm a little bit leery more in the campaflumab or in the reduced intensity regimens. Um, Mike Jordan and his group have shown that a dose of emapalumab before that with HLH does help engraftment, but you also know that you need some graft versus marrow effect on the back end of those transplants in order to get the graft in. And so if you block that a little too strongly, I do worry that you could actually cause more harm than good. And so again, I think it's context dependent. I'm very comfortable with it in the myeloablative setting. I think it still needs to be worked out in the reduced intensity setting.
Okay, so it goes with my your answer induced my second question, because if you feel so comfortable in using it, you say even if 6L9 is normal, it's because as you say, things can change dramatically quickly. And again, in the context of myeloablation, I understand well. So this means, if I understand well, that you are not afraid of using it, and that the side effects of this drug, you didn't see much, correct?
We've not seen on our protocols a lot of toxicity related to the to the drug itself. We've seen patients reactivate CMV quite a bit in patients both on the, studies that we have as well as patients off trial, consistent with what we would see even if they weren't going to transplant, just getting either a JAK inhibitor or emapalumab. And as long as we are aggressive in our antiviral strategies, we have not found that to be problematic. But it is something to keep note of, that when we do start at,
Infections, and particularly CMV.
in particular CMV, the viral
Okay,
reactivations are the big
okay,
ones.
viral. Okay,
So
and did you see my third question? Because it works on T cells, and you said if there is not enough myeloablation, then it's gonna inhibit the T cell part of the pro-engraftment coming from the donor. I understand that, but then does it mean it works also for GVHD?
there is a study out of City of Hope looking at emapalumab as a potential for GVHD prophylaxis or treatment. So, I think the jury is still out on that. I thought your question was going to be, does it affect the ability for PTCy to work, right? Because the whole premise of PTCy is that it kills the activated T cells, and if you have emapalumab on board, are you making the alloreactive T cells less reactive and then making Cy less um, sort of less effective? We have not yet seen that, but it is something we're keeping an eye out for. Again, it is something to watch for.
Okay, so at the end of this podcast, everybody should use emapalumab for any bone marrow transplantation in the IAI field, correct?
I think at least in
Give
the
me
immune
something back. Give me,
dysregulations,
give
I
me,
think
give me a
at
dark
least in
point.
in the immune dysregulations, we do use
Yeah,
emapalumab for many of them. Now, if there
yeah.
is another targeted therapy, right? If you have a CTLA-4 haploinsufficiency, EMA might not be the right choice for you. ABBA might be the right lead into the transplant, right? So I think it is precision guided, right?
Mhm.
So we just recently did an SJIA patient, and we used MAS825, which is the IL-18, IL-1 bispecific instead of EMA, right? Because that was the pathway of disease that that patient had. So I think bridging into transplant, all patients should be bridged, right? Whether or not EMA is the right choice for all of them, I think, again, if you have a better option, a more precise option for that patient, going with that precise option might be the better strategy. And that's how we approach it right now.
Yeah, just temper the disease, cool down the disease, cool down the inflammation to whatever pathway you need to do depending on the pathophysiology of the disease of that patient. Okay,
Now, Joe, I
interesting.
wanted to ask, you've been looking into things beyond the traditional, so to speak, use of emapalumab in this transplant context, at least in the direct transplant context. Can you talk about that? Like some of the use of emapalumab and STAT1 gain of function and things like that. I think our patients would be interested to hear about.
Yeah, so I think a lot of the diseases in which we use JAK inhibitors, right? Emapalumab is another strategy for treatment of those patients. Now, we have to remember that emapalumab is an expensive medication, and it is an IV delivered drug. And not an oral pill. However, the side effect profile is such that it is sometimes much more tolerable than some of the side effects that we see with the JAK inhibitors that we're using. And so we have used for some patients, let's say a STAT1 gain of function patient that has a particularly bad enteropathy, is not absorbing oral medication all that well. We have used emapalumab with great effect in some of those patients, both as therapy to help them sort of improve their quality of life, and when they were ready to go to transplant as a lead into transplant. We've used emapalumab a lot in what we call interferon-gamma mediated hyperinflammation, what was traditionally called secondary HLH, um, across a variety of triggers. And we've shown that that has been tremendously helpful, again, in bridging patients to therapies for their underlying triggers, and really increasing overall survival for those patients in the near term. So I think there's a lot of uses to be explored with the drug. We have several clinical trials that are up and coming soon, so hopefully we'll continue to explore those in a prospective, rigorous manner.
Does the PIDTC help you to set this up in all the centers, and it's easier to do that all together than just alone in one center?
I think it's impossible to do this in one center. All of these diseases are rare. They're sort of you get one or two. If you're a big center, you may get a few more as referrals, but it would be impossible to do this type of research in only one center. And we're trying to grow PIDTC and incorporate some of the hyperinflammatory syndromes, and some of the sort of interferon gamma mediated hyperinflammation. I don't think it would be possible without infrastructure like the PIDTC has.
And because we are very passionate in our things and in the cytokine and this and that, and we go quickly, if you had to shorten it and to summarize it for patients, for parents, for families who may not have, who don't have our background in understanding and juggling with all those things, how would you put it in a lay term?
I think that Gamifant or emapalumab is a fantastic drug for patients that have that particular interferon gamma pathway dysregulated, I think it has a lot of potential use both as medical treatment and to help with transplant in those disorders and in a variety of other disorders for transplant. Um, but I think again, it has to match the underlying pathophysiology. I don't think it's a drug that should just be given willy nilly
Yeah.
either.
It's not a miracle. How do you say that in English? Miracle
Yeah,
drug, yeah?
I
miracle
mean,
Miracle
it
drug.
drug
can
Yeah,
it can be a miracle drug for the patients that are the
that
right
need it,
patients for it.
that actually
Yes,
need it. Yes,
yes.
it has to be targeted. Okay.
yeah, that's great. Well,
Jack, do you have other questions on this specific
I have
topic
one more
before?
question,
Yeah,
a
go
working
ahead.
man question, because outside of some of the academic centers, I'm imagining some of our colleagues in transplant. Well, a lot of transplants are going to be done in an academic center, but I'm wondering the affordability of Gamifant or Emapalumab, and if that becomes an issue, if a patient's not on a study. Is it easy for our colleagues? And I'm asking because I'm not a transplanter. I don't know. How easy is it to get access to this drug if you're not on a particular study or something like that?
The cost, like I said, is um, quite high for doses of imapalumab, and it can get to being cost prohibitive in some of the bigger patients because it is per milligram dosing and per milligram pricing. Um, that said, I think as the data have evolved, and that there is more indications that emapalumab can salvage grafts in some cases, can minimize toxicities in other cases, right? The sort of the fiscal argument there is that we can save ICU days in some of our secondary HLH patients, that we can potentially, if we give a dose, if we're able to salvage a second graft, right? We've saved a second transplant. That's a huge cost there. So there have been sort of push and pull with P&T committees, and there have been some loosening of the spigot. I also am hopeful that as additional indications get onboarded, that the company producing emapalumab may be able to lower the cost because you have to remember this was a drug that was really developed and indicated for only infants with a very rare disease, and so in order to make it viable, they priced it at this level. And now that we're using it in all these other indications, I'm hoping that they will review that sort of appropriately.
Yeah, great points. And again, it's great to get your expertise on this. Unless Ellie has more questions about
No,
this
I-
product, I think
I'm
we
okay.
could.
I feel better.
You feel better. You're going to start using it on everyone. Unless that, I think we could touch base a little bit on your work with the PIDTC, especially with the patient presentations. I should say case presentations about difficult patients. That sounds really exciting to get all the brain trust together, either in person or virtually, to discuss challenging cases. Can you tell me a little bit about that?
Yeah, so I think the impetus for that is that at least at our center, and I'm sure this is at many centers, we've now been doing whole genome screenings on every baby born in our healthcare system that signs up for the study, and we're finding lots of genetic variants that could be disease causing, but some of these diseases are not 100% penetrant. And so the question of when to transplant, who to transplant, is becoming more and more difficult for us to answer. And some of us just don't feel comfortable anymore making these decisions alone. So that was the impetus for it. And then we realized that there were other cases out there that were maybe declared themselves as needing a transplant, but were so complex and difficult, and the center didn't particularly have expertise in that specific PERD or that specific inborn error of immunity. And so being able to gather a host of experiences really helps us deliver the best care for our patients.
I think also one of the objectives is to do at the same time both teaching and learning for everybody, because when you hear from such a rare case, even if you're an expert in this you learn, and you learn from the opinions of others. So I think it was something that was missing, actually, I think, in the PIDTC network. So we are very happy that Joe has decided to take that on his shoulders. How many sessions were there? Only one already?
There was one, we have another one tomorrow, and the response has been really nice that we've added additional overflow session now for our next meeting because we have so many cases that have been
Yeah.
submitted. So
Which is
we're
not a
excited.
surprise. It's not a surprise. There are tons of crazy cases and many situations where doctors are not very sure of themselves and would like to just ask for opinions, exchange ideas, and maybe they hope they are not missing something obvious or something that has been done elsewhere with a terrible result. They don't want to reproduce it. So I think it's important, and I'm not surprised that we already have 5, 6 cases on the
Docket
pending.
for
Yeah.
so.
And
That's
Joe,
good.
is it only certain diagnoses, or are clinicians able to, any kind of inborn error of immunity or transplant case, are they able to query the group and get some input?
Yeah, I think it's primarily for any inborn error of immunity, or transplant, or any other, therapeutic intervention. So spanning diagnosis, transplant, workup, whatever the question is, um, and anything that's adjacent to inborn errors of immunity is welcome as well.
Yeah.
Right? This
Difficult to
is
manage. We are the PIDTC, Primary Immune Deficiency Treatment Consortium, and it's a management thing. So I think it's not just transplantation. We all agree on that. Yeah.
And questioners who aren't formal PIDTC members, if they have a particularly challenging case, would that be something that they could ask to participate?
So I think half of our pending cases are from people that have not traditionally participated in the PIDTC, which I think
Great.
is fantastic. We're encouraging trainees to join as well and be the presenters. So if you're working with a fellow or a junior faculty member, we encourage them to be part of the conversation. We encourage them to present and really hope to engage them in the PIDTC. So
Yeah, and it's one of the
anybody's welcome.
mission. And it's one of the mission of the PIDTC. It's to spread and to not to be reserved to the core centers or even to the affiliated centers. Anyone with such a condition can come and discuss. And as we said, it's a teaching and learning process altogether. So we will all learn. So that's important.
That's what I was hoping you guys would say. It sounds like a very cool thing. I'm sorry that I haven't personally been involved in it, but it sounds like an amazing opportunity to learn.
Yeah.
Have you noticed any patterns, both of you, at these conferences where we discuss difficult cases? Any patterns or pitfalls that you think clinicians, maybe as a general phenomenon, fall into that maybe
I think it's too early, correct, Joe? We just had one.
I think it's
too
too
early?
early, but having seen all the pending cases, like all I can say is these are head scratchers and
Yeah,
difficult
a lot of
cases,
weird
right?
stuff out there. Yeah,
These are not run-of-the-mill cases.
or they wouldn't need to discuss it with the whole group. Oh, awesome. Well, any other things you want to tell us about your research work with the PIDTC or the case presentations?
No, I just encourage people to really be involved in the case presentations, really send in your cases. PIDTC has been great. It has been incredible for my career. The infrastructure it provides, the sort of collegiality. I really, one of the most enjoyable parts of my career is all of the things that I do with PIDTC. So I'm grateful for that.
I did
And look
not pay
forward to
him to
many
say
more.
that. I
He
He's a
did
promise.
not.
plant.
He did not. But
And if someone
it
wants
is
to join your
enjoyable.
case presentations, like, is there an email that they could use, or I can throw it up on the podcast when we air this, a particular contact point, or just go Google the PIDTC and search through there?
So it is the two coordinators, so Jessica and Lisa. So I can send you their emails if you want to.
Yeah, maybe I'll put it
Throw
in
it
the
up on
show
the
notes.
podcast,
That'd be
yeah.
great. All right. Well, thank you so much, Joe.
Thank
Thank
you,
you, Joe.
for
It was great to
inviting
have
me.
you.
Nice to see you guys.
Thanks
Take
a lot.
care.
Alrighty.
That's all for today's episode of Immune Matters. A huge thank you to Joe Oved for sharing his time, his expertise, his passion, and the stories he had with us. And
Yeah, if you enjoyed this episode, please be sure to subscribe and share it. We're always looking to get more followers with anyone who might be interested in this, patients, colleagues, or friends.
And as always, you can learn more about PIDTC and find additional resources at the site https://pidtc.rarediseasesnetwork.org, and it will be written on the screen.
Yep. And thanks for listening. We'll see you next time. We'll try to make it so it's not so much time between episodes.
Bye.
The Primary Immune Deficiency Treatment Consortium, PIDTC, is a part of the Rare Diseases Clinical Research Network of the Office of Rare Diseases Research, ORDR, National Center for Advancing Translational Sciences, NCATS, National Institutes of Health, NIH. This work was supported for the Division of Allergy, Immunology, and Transplantation, National Institute of Allergy and Infectious Diseases, DAIT, NIAID, and the ORDR under cooperative agreements U54AI082973 and U54-NS064808 and grants R13-AI094943 and 1R24AI184316-01. The content and opinions expressed are solely the responsibility of the authors and do not represent the official policy or position of the NIAID, ORDR, NCATS, NIH, HRSA, or any other agency of the U.S. government.